Welcome to my podcast. Today I'm going to talk about another common case that you can face in the clinical setting or the hospital setting. So basically, after always you agreed that you introduce yourself, you ask the patient name and date of birth, and then you will ask, how can I help you? The patient might say, I'm having pain in my tummy, in the upper part, might point out their finger. I might say that I have general fatigue and I'm feeling like fullness in my tummy. So all of that could denote to anything related basically to the liver. So I'm going to talk about something called metabolic dysfunction associated steatotic liver disease, and it's a name which has been changed from the term which has been used before called non-alcoholic fatty liver disease. This has been replaced recently in 2023. And it's implied that there is like a presence of one or more of the cardiometabolic risk factor with absence of alcohol intake in those situations. And it's affirming, and it's which is affirming and not stigmatizing. And the picture range from simple stenosis without hepatocellular injury to basically hepatocellular ballooning and lobular inflammation with associated degree that can go from non to cirrhosis. So it's basically from F0 to F4. And in most of the situation, those kind of cases being diagnosed incidentally or accidentally. And as I mentioned, the patient usually they have the sort of symptom whereby denote that there might be something going on with the liver. In most situations, it's associated with hepatomegaly and stigmata of chronic liver disease. And the liver enzyme can be normal, as one of the authors reported, who's called Browning. However, any persistence of abnormal liver function test, in particular alanine transferase and gamma glutamate transferase, which is often observed in those kind of situations. And often the diagnosis associated with liver disease in that situation, we need to assess the liver stage in order to know which stage the patient is in. In most situations, the main remedy or the main management is asking the patient to have like a lifestyle modification and optimize if there is any associated comorbidity. Say, for instance, if the patient has diabetes or diabetes type 2, if the patient has obesity or dyslipidemia, in order to have a positive impact. So we need to emphasize the necessity of those kind of changes in the lifestyle. And as we all know, there is certain agent nowadays, it's being used, and especially if the patient have diabetes and have obesity, those are like GLB 1 receptor agonist, and I mean by that semaglutide. And also there is other agents which can be used like GLB and GIB 1 receptor agonist like tribzapid, and SGLT2 inhibitor like dapagliflozin. And also we need to emphasize about using statin as well. And if there is, of course, morbid obesity, you need to refer for bariatric intervention, which has shown benefit to liver-related condition with outcomes. Also, we need to have like 3-yearly assessment once there's a clinical picture that has been seen. And also, we need to screen for certain complication like advanced liver disease. I mean by that, varices and hepatocellular carcinoma. And usually the risk factor that we need to know is polycystic ovarian disease, certain also cetogenic drugs, and we need to emphasize that because we know certain patients, they are on corticosteroid and steroid for quite long time, so that's one of the risk factor. Patients who are treating with methotrexate, it's another risk factor. Patient like epilepsy who is treated with sodium valproate, so that's another risk factor. Amiodarone and tamoxifen. And also, if there is a certain patient who has certain diseases like hypothyroidism, celiac disease, if they are not able to eat and they have parenteral nutrition, or if they have Wilson disease, all of that constitute one of the risk factors for this disease. And also, when I said about obesity, I meant by that mostly the central obesity with increased body mass index, and the waist circumference is increased. It can be like in men more or less or equal to 94, and female more or less 80. So we need also to put in mind that we need to screen any patient that we accidentally knew about this condition. So we need to look for if they have comorbidity like diabetes type 2, hypertension, dyslipidemia, and we need to send for thyroid test, because sometimes they might be subclinically hypothyroidism. And as I say, there are certain criteria to diagnose metabolic syndrome. So it's basically 3 out of the 5, according to Alberti in 2009. It's about central obesity, male, if it's more or less equal to 94 or more, in female either it's 80 or more, if they have impaired fasting blood sugar, if they have increase in the level of their triglyceride, and if they have low in the level of high density lipoprotein, which is the good cholesterol, and if they have hypertension. And we need to know also patient with chronic liver disease, usually they have osteoporosis and they have the fragility fracture, and comparatively to the general population. So we need to arrange for their bone mineral density assessment in order to know what's going on and how's the situation. So in this podcast, I just mentioned about basically metabolic syndrome and what's the new definition and the term used for metabolic, for fatty liver, which is metabolic dysfunctional associated steatotic liver disease, whereby there is a risk of cardiometabolic element in those cases who have nil of alcohol intake. Thank you.